Thank you for the introduction and the opportunity to speak here today. Today I'll be speaking about ischemic heart disease and AI in CAC quantification and localization. I have no conflicts of interest. As already been discussed this morning extensively and also yesterday, ischemic heart disease. Atherosclerosis is the main cause of ischemic heart disease, and it's the leading cause of global morbidity and mortality. 9 million deaths annually and 16% of deaths globally. We know there is a clear need for early detection and effective prevention, but this is still lacking globally. The coronary artery and calcium score, also already discussed a lot, but I'll just go through it so we don't forget. It's an imaging biomarker for subclinical coronary atherosclerosis, and many studies have already shown that it's a predictor of atherosclerosis cardiovascular disease risk, and therefore it's also been included by multiple international guidelines that recommend to report coronary calcium score on all CT scans, so also non-gated CT scans such as lung cancer CT. Because we know it reveals the risk before symptoms start. We've heard about the power of zero today and the treatment gap, specifically also in lung cancer screening, to identify the individuals that should be on treatment but are not yet. Because in lung cancer screening, we know we are looking at an older population with a heavy smoking history or are still smoking. And we've seen in the Nelson study and actually also in the NLST that the mortality rate for lung cancer and atherosclerosis cardiovascular disease is similar or maybe even higher, such as in the NLST. Multiple lung cancer screening studies have reported the calcium score prevalence. These values are, however, very variable because it's also difficult to compare the cohorts because there is a lot of difference in inclusion criteria within the studies, but also in the calcium scoring reporting methods. Most actually use visual methods, often also non-standardized, sometimes just free text. It's reported as an incidental finding. Others use more structured reporting or like an ordinal grading score. And only few actually use automated coronary artery calcium scoring or automated quantification. But still, if we compare these values to asymptomatic population of the MESA, we see which reports 49% calcium overall and 70% in white men, which is in some cohorts more comparable. We see in general much higher calcium score prevalence in the lung cancer screening population, as we also expect. But therefore, there's an opportunity for AI. We know coronary calcium score is time-consuming, and I think in the poll from the panel this morning, we already saw that lots of people use also AI methods to reduce time. We know it's systematically underreported, so AI can also be an opportunity to report the calcium score for every scan, because it will not be tired or miss a scan such as humans can do. And we have a big opportunity because of the high volume of lung cancer screening CT. And this is for the US, but we also have now many programs in Europe and around the world, and also in the future, a lot of upcoming opportunities to perform large-scale lung cancer or cardiovascular screening. And we can use AI for this, to do this fast and reliable. AI-based coronary calcium scoring is based on to locate the plaques and also quantify it. It's based on the density of the calcified plaques, but also how do you determine if it's in the coronary arteries. This can be difficult because of other cardiac calcifications in the aorta or in the valves, other non-cardiac structures that have high density, such as stents, noise, and the low coronary artery to myocardium contrast. However, many studies have already been performed on in-house made or commercially developed AI-based methods. And overall, we've seen when they compare to the AI method to manual segmentation and expert segmentation, we see overall a very high intra-class correlation. And this is also specifically for non-gated chest CT and a good correlation with Agatston risk categories. However, We can see a difference in methods. Most actually use now more deep learning methods, which I won't go into now in the specifics, but what I want to look at is also what the data is trained on. Some studies focus specifically on the non-gated application and start the training also of the model on non-gated CT, while others also use sometimes gated CT and then refine the model with non-gated CT. But it is important to know what was the model trained on, what is the intended purpose, so don't use a model that's made for cardiac CT or non-gated CT, which sometimes still happens. And is it generalizable to your population and data? Is the type of CT data a similar quality to your data? Because if it's not, it will definitely give you different results. We've seen that performance decreases with external data sets, and a study that's been published in 2020 also focused on this and looked at specific protocol data-specific examinations. They started with the baseline training of low-dose chest CT, then they added protocol-specific scans, sometimes also PET-CT, and looked at the performance, which increased, but if they used a combination of protocols, they actually saw the highest performance, and which also makes it the most generalizable. Other studies have also focused on motion artifact recognition. This can be specifically of use in lung cancer screening, non-gated CT, where these can be more common. And it could be used as also to flag any scans that have more motion artifacts and therefore would have a lower confidence in the calcium score. And also if you want to compare calcium score over multiple time points, you can also know if you have to exclude one because of possible motion artifacts. And other, well, I call future improvements, but most AI models actually already include this information, which is plaque localization, which vessels are involved, because we know the left main and LAD have a worse prognosis, and also the number of affected vessels. And most of these, this information is not yet used or communicated to primary care. Other thing we can focus on is also extracoronary calcifications. The Rotterdam study already showed that if you include calcifications of ECC, it can improve risk prediction, specifically also the thoracic aortic calcification. And in the MESA study, they used actually an ordinal score, and they showed that risk prediction improved when predicting coronary events and mortality. And this can also be seen as maybe an option to include as an incidental finding extensive aortic calcifications, valve calcifications. And actually an AI model has already been developed for this, and they focused on multi-site, multi-protocol CTs, non-gated CTs, and segmented successfully coronary artery calcium, but also thoracic aorta and cardiac valve calcifications. Another implementation possibility is to also segment stents. Not all AI systems do this, and then this causes more false positives, which are unnecessarily referred again to primary care. And it can also be a lot of information to show what percentage of your population already has undergone intervention before, because the lung cancer screening population is not by definition an asymptomatic population. So of course, a proportion of these already have undergone intervention. And this is usually not known within the lung cancer screening workflow because it's not linked to the clinical database. So overall, we know AI calcium score quantification has a strong agreement with manual methods, and it can support effective risk stratification and without additional reading time and a workflow burden for within lung cancer screening. So there is a clear future for standardized AI-based CAC quantification. And we have to use this opportunity to indeed perform this cardiovascular disease screening, but validation is essential before clinical implementation. You have to know if it is generalizable to your data, to your population CT system, temporal resolution, reconstruction parameters, because you have to know if the data that comes out, if you can trust it. Thank you for your attention.